quite as tall. Hi, everybody. I'm so happy to be here, but I have to say, I didn't see where Tammy walked down to, but I'm feeling a little PTSD right now because last year during our presentations, we had to say the word Canada as many times as you could to win socks. I don't know if you remember that. So stressful. I did get one pair of red socks, but I also closed down the party last night because I noticed they were sitting on the tables, and I'm like, hey, are you going to use those gloves? Yeah, do you need that hat? And so I now have like socks for Christmas for 27 of my closest friends. Let's say Canada on them. But no, super excited to be here today and to talk to you about. I've been listening for the last couple of days, all these great organizations and these great initiatives and these large groups of people collaborating and coming together. And I want to take just a few minutes and share with you some kind of amazing things that happen when a few wild and crazy people think outside the box and then do something wild and crazy, and you kind of learn some amazing things. So this all centers around access, inclusion, and mentorship. And we all talk about diversity, equity, inclusion. We've heard it, right? For the last couple of days, we all talk about it. But what does it really mean to do that? So I'm going to take you on a little road trip we went on to kind of figure that out last year. So if you don't know, this is Judy Carey from MGH. She's in the room somewhere in the back here. There she is, my partner in crime. And we hit the road. And I want to share with you what we thought was going to happen, what actually happened, and what we learned from it. So why did we do this? Well, it actually started at the International Alliance in San Diego. And I was sitting at the dinner, and I'm listening to everybody around me talk, and I didn't know the people at my table. And they're like, how do we get more people involved in clinical research? Why is clinical research really only Caucasian white people in the United States? How come they're only males? Do you think they're educated or whatever? And I'm looking around at these people thinking I'm being punked, and I turned to the girl next to me, a very nice young lady, and I said, well, if you want to know, why don't you ask them? And everybody kind of stopped chewing their salad. It was like really rough salad. I remember this kale salad. And they all stopped, and it happened to be that who I was sitting next to was Mary from Cytokinetics, who said, I'll give you some money if you want to rent a van and go talk to people. And this is how our van trip started. So with the help of Cytokinetics and MT Pharma, Judy and I hit the road as NEALS and MGH IRB approved study with the support of the ALS Association helping us find our way around because we're both geographically challenged. So Tracy Ali, if you're in the room, she helped us, her team, try to figure out how to do this. And here's what happened when we did this. So if you ever have heard the term social determinants of health, or SDOH, it's all those things that we all talk about when we ask the questions, if then, well, if they're educated, then will they do this? Or if they're of this culture, then will they do this? Or if they are not this, then will this not happen? And all of those things, in a nutshell, it's pretty much saying who you are matters, right? How you react in a situation, who you are, it does matter. And those are your social determinants of health. So we spent a long time at MGH looking at social determinants of health and deciding what we were going to do. It's not something that happened overnight. You can read this some other time, but it's been many years that we've been taking in at MGH, Mass General Hospital, sorry, I use those acronyms, question after question that come in from all over the world about clinical research, to where we created a patient navigation team that I talked about last year, and then we implemented technology to track the kinds of questions that we were getting, and then we created resources to support the kinds of questions that we were getting, and then we started partnering with the Les Turner Foundation, who's awesome at resources, so they could translate and make those even better. And so this has been a real process to that fateful night where Mary said, do you want to rent a van and go drive through New York? And we said, yeah, we do. And we put together a team. And this is our team under Dr. James Berry. And we decided that we are going to convince the IRB that we could learn a lot if we just went and talked to people in all different settings within the Massachusetts, New York area. The plan. Everybody knows why you have a plan, right? So you know it didn't happen. Our plan was to compare the knowledge about clinical research and participation in people living within 90 miles of a multidisciplinary clinic, according to those who weren't. And then we were going to take that information back to MGH and the SDOH study that was already in progress. We were going to inform them what we've learned. We were going to make a few modifications to that study, and we were going to keep it going stronger than ever. That did not happen. We went to Plan B, and we realized right away at our first stop that we had several biases that we didn't even realize that we had when we wrote our IRB-approved questionnaires. We had assumptions and questions culturally that made sense to us, but we didn't realize we were already assuming things when we asked the question on the road. And we also realized there was absolutely no substitution to being there, to driving the drive people had to make, to doing what they had to do, to participate in clinical research, and to talking eye to eye with those people. So we did it. And the first thing we learned, write this down, if your car requires gasoline to run, put gasoline in the car if you expect it to run. Because when Judy came to pick me up, the car started beeping. I'm like, what's wrong with the car? She's like, don't worry, it's out of gas. I'm like, this is a road trip. Like, what are we gonna do? She's like, well, I kind of hoped I'd get gas before you noticed that. But we did make it. We got gas, and we headed out on our trip. And we went to different areas. So we went to urban areas, and they had different challenges. Like, it was kind of a drive to get out there, and there were times when traffic was bad, but when we got there, it was really beautiful, and it was peaceful, and it was a really good quality of life, right? So we're like, well, suburban, that's where those multidisciplinary clinics are. And by the time we got through that parking garage, we had said words we didn't even know either of us knew. It took hours to find a parking spot. We couldn't find the right building. Once you got into the place, you had every service you needed. Everybody was there to help you, but getting there was really, really difficult. So we headed out to rural America, and we drove and drove and drove and drove 1,200 miles, and it was beautiful. It was absolutely beautiful, and we had no services. We were crying because we could not find a cup of coffee. We were in the middle of nowhere at all, so they had very different challenges, right? And then we went to the VA. We were like, well, let's go to the VA and see how it is. And there we learned everybody knows the answer to the questions, but they all know the same answer to the same questions. Like, everybody fell in line, and we just kind of tried to fall in line with them. So every stop we went to had totally different challenges. What we came to was the universal truth that there's no single social determinant of health that creates an equity of access. It's a combination, and there's a gazillion combinations of those social determinants of health, and that we all, everybody impacted by ALS, struggles from the same challenges, just some people have more resources to overcome those challenges. And so it looks different depending where you are, but the bottom line, the bottom of everything was it came down to trust, who they trusted in their experience. And it wasn't, sorry clinicians if you're in here, it wasn't always their neurologist. A lot of times, like in rural America, it was the traveling nurse Trish, and we could not get in to see, like, between us and the ALS Association, we pulled every string we could. We could not find any patients in this area who would let us in until traveling nurse Trish called them, and they're like, oh, come on over. So we ended up extending our stay and traveling even further, just to talk to people who would let us talk to them because they trusted the people who cared for them. So in summary, we thought it would be really beneficial to move forward focusing on that universal design, to kind of remove barriers that everybody has in a way that the least common denominator benefits the most, but everybody benefits. So what we decided to do was that we needed more educational support, but we didn't need to educate patients because what we found out that geographically, it didn't matter. People out in the middle of nowhere, it wasn't that they didn't know about clinical research. They didn't necessarily want to participate in clinical research. And the people right next to the multidisciplinary clinic, It wasn't that they didn't know about research. They may or may not want to participate in clinical research. And we heard those same things. Like, for example, if they were slow progressing, they didn't want to take the risk and speed something up. And if they were fast progressing, they didn't maybe want to spend their time doing that. And even those common things such as transportation, like, think about it, like, look around the room. Find a man that's like 6'2" or so. Imagine him laying on the floor, and I'm going to say, hey, my car's parked in the parking garage across the street. Could you get this guy into the car for me to go to a clinical trial visit? Like, think about that. So when you get this poor fella into the car, it doesn't matter if you travel 5 miles or 500 miles. It wasn't a geographical issue. So we really needed to find a way to educate those healthcare providers and to support those healthcare providers, not the patients. The patients knew. People impacted by ALS, they know their challenges. Thank you, Jess. So we needed to look at the other side of the coin, and we needed to address diversity not at one level, but in communities that within themselves are diverse, such as in our world, veterans and asymptomatic carriers. We need to spread the word through publications because that is what you people in academia do. So we are in the process of partnering, if Fernando's in here, with ALS TDI on their new Trial Navigator tool for a provider version to push out information about clinical research into those hard-to-reach areas where people don't have to go look for it. If you're a provider, we're going to give you what you need at your fingertips. We are having quality discussions and new Pass It On project that you'll hear about in a couple of days for healthcare providers. It's going to be super cool, but trying to open those lines so that people can communicate and support each other from the healthcare provider aspect. Integration of the key communities. We're building, creating, offering, and providing additional services, working with Dr. Ileana Howard at the VA to and the new Veterans Actions Group under the ALS Hope Foundation. You're going to see wonderful things coming out of that group that we're really focusing on getting new messages dispersed out through that diverse community. And of course, spreading the word. We're working on publication 1, which is just our opinion about what we learned. Publication 2 will be our thematic analysis, and publication 3 will be the outcomes of that. And that's really important because we need to keep talking about this, because the truth is, hope shouldn't be a privilege. It should be something that exists for everybody, and who you are does matter, and you should have hope as well. So the publications are really important to us as well. But the bottom line is that we really believe that by knowing better, we can do better, and we can create better outcomes for everybody. So thank you for listening about our trip.
Thanks so much, Allison. That's fascinating. So, questions over there, please.
Hi, Jen DiMartino from ALS One. So my question is, once they let you two fun ladies into their home, did they open up to you about just general discussion about what their main frustration is about living maybe so far from, a hub, or, did it take them longer to get diagnosed? What were their main, I guess, complaints or issues that you took away from that?
Oh, thank you, Jen. That's a perfect question about what we learned, because we went away thinking that, oh, they must feel bad that they live so far from a multidisciplinary clinic. But the truth is, no, they didn't. They chose to live there, and they were perfectly happy. And we had put our expectations onto them. And so it might have been a few times that Judy said, Allison, you're such a snob on this journey, because I would say, well, don't you think they want that? And she's like, why do you think they want that? They didn't say they want that. They were very, very happy. The dog did bite me when I walked in, but we just had to deal with that. I think it was a me thing. But that was part of the bias that we learned, and people were very happy in whatever environment they chose. And I think the people who had the hardest time talking to us, and Judy, jump in and correct me if I'm wrong, were past family members who had lost moms and dads, were the group that had the hardest time talking about what their experiences were.
So one question just in front of you.
Hi. Sorry, didn't mean to yell that right into the microphone. I'm right over here, Allison. There you go. Sarah Maguire from ALS Canada. I really appreciate this initiative. Congratulations, this is amazing. I really appreciate you outlining the systemic and also personal unconscious bias. The thing that I'm curious about is the nature of unconscious bias is it's usually unconscious. So what was the thing that sparked your awareness before you even started this plan?
Such a brilliant question. So it didn't spark our awareness before the plan. And I'll tell you, we got a lot of pushback when we started talking about, hey, we're heading out on the road, and we kind of got a little bit of this, oh, that's so cute. Enjoy yourself. You guys are going to have so much fun. You know, it was kind of like that. And then when we came back, and as we were calling people on the road going, we have to change our protocol because this is not right. And it happened for me when we sat down to talk to a healthcare provider because we had went out to a very rural area and the people were a genetic carrying family. And my partner wanted to really tell them that research was happening on their behalf and they could participate and not know the results. And they were pushing back really hard and did not want to know. They did not want to be involved. And that really sparked some conversation for us on the next drive because I'm like, we really assumed everybody wanted to know. And we based our questions on that. And when we got to the next healthcare provider, we had a really long conversation with them. And she really schooled us a little bit about reading the room and how important that was. And I think that's when we kind of stopped and pivoted and said, let's look again at what we thought we knew. And that's how we were able to get some really good data out of it with the help of a data analyst. So
one last question with Katie, please.
Thank you. My question is about your outcomes publications. I assume, Allison, because I know you a little bit, that you probably talked broader with these people than just about their access to clinical research. You probably got into lots of, conversations about other frustrations and, do they go to support groups and things like that because you're just a friendly person. So will you be looking at any outcomes outside of what the research project was initially for? And is that true that you ended up hearing lots of other stories that weren't related to research?
Thanks, Kathy, for the compliment and great question. So that's why we did it as a qualitative study, not quantitative. We were set up by our team to just talk. We talked to these people for hours. We asked some questions, but we just talked. And then we turned in all of our recordings, and a data analyst spent weeks and weeks and weeks coming up with the themes that came out of that and the different areas to focus on and how to delve down into that. And the reason that we chose not to start with that as our publications is because we can't statistically prove anything. It was a very small study. It was a random van that we went through a random East Coast area. So we wanted to set it up as an opinion, as a qualitative ethnographic study, share what we feel like we learned, share the outcomes from the qualified data analyst who gave us those themes, and then we'll start talking about each of those, how we're going to measure them, how we're going to approach them, and then we can start tracking the outcomes of what we've learned. And so next year I might have some more detailed numbers and data and information to share about that.
Okay, thank you so much. I think we'll stop there. Thank you for both speakers. This was absolutely fantastic. And we're up for a break until 3:45. So about 10 minutes.